Dear friends and colleagues, it's good to be part of Euro-Asian Neurology Online Summit. Great greetings from Sarajevo and Bosnia and Herzegovina. As you can see, my topic is treatment of testosterone deficiency, differences in the guidelines. First of all, I would like to say about some facts about testosterone deficiency. Testosterone is an essential hormone required for the developmental growth and maintenance of male phenotype during the whole life. With increasing male life expectancy worldwide and development of adequate testosterone preparation, the prescription of testosterone has increased tremendously. Testosterone replacement should be based on low serum testosterone and related clinical symptoms. Testosterone deficiency profoundly affects men's quality of life. Men receiving testosterone therapy often experience resolution or improvement in their sexual symptoms and non-sexual health benefits. Testosterone has been available since 1930s. The diagnosis and management of testosterone deficiency can be challenging and many controversies still exist. The prevalence of testosterone deficiency varies between 10 to 40% and is known to increase with age, with an abrupt rise in men aged 45 to 50 years. Specifically, testosterone deficiency coincides with the presence of comorbidities reaching as high as 80% in patients with multiple comorbidities. Testosterone deficiency is most commonly seen as component of male hypogonadism, which is a clinical syndrome related to inadequate production of testosterone, androgen deficiency, and reduced spermatogenesis. Male hypogonadism represents biochemical hypogonadism and/or symptomatic androgen deficiency. The prevalence of biochemical hypogonadism increases with age, ranging from 12% among men in their 50s to 49% among those 80 years and older. Symptomatic androgen deficiency, on the other hand, is the presence of at least 3 signs or symptoms consistent with androgen deficiency and confirmed by a serum total testosterone or free testosterone below the normal cutoff value. Symptomatic androgen deficiency is significantly less prevalent, 6% only, than biochemical hypogonadism. Symptoms of androgen deficiency are often non-specific and include diminished libido, erectile dysfunction, weight gain, fatigue, anemia, poor concentration, and depressed mood. There are significant differences in practice patterns regarding diagnosis of hypogonadism, with some physicians placing more emphasis on biochemical hypogonadism, others on patient-reported symptoms, and most settling on a combination of two. Despite the recent surge in usage, the diagnosis of testosterone deficiency remains a challenge. This is partly due to diagnosis being dependent upon establishing presence of clinical symptoms and low serum testosterone levels. However, achieving these two criteria remains difficult due to lack of standardization regarding the overall evaluation and management of testosterone deficiency. This lack of standardization is due to several factors, including wide variation in presenting symptoms, limited clinical correlation between serum androgen levels and symptoms, and various issues with laboratory processing and quantification of serum testosterone levels. Several specialty societies and expert groups have attempted to standardize the diagnostic process, including the United States Endocrine Society, European Association of Urology, International Consultation on Sexual Medicine, and joint guidelines representing numerous international andrology societies. Broadly speaking, these guidelines emphasize the importance of diagnosis in men who first demonstrate clinical signs or symptoms of testosterone deficiency, followed by the commutation of a low serum testosterone level only in individuals who do not exhibit easily reversible causes of testosterone deficiency, such as medications or acute illness, as previously discussed. These guidelines provide a good framework with which clinicians can practice. For example, previously recommended by the International Society for Sexual Medicine that those with total testosterone below 200 nanograms per deciliter definitely have hypogonadism and should be treated. Those with total testosterone above 400 definitely do not have testosterone deficiency, and those with total testosterone between 200 and 400 should be treated based on their clinical symptoms if they are symptomatic. No universal consensus has been reached, making the diagnosis and treatment of hypogonadism a controversial topic. Although cutoff is an important component in diagnosis hypogonadism, guidelines from the United States Endocrine Society define hypogonadism as symptoms of hypogonadism with total testosterone below 300 nanograms per deciliter, which differs from the cutoff of 349 nanograms per deciliter recommended by the European Association of Urology. The prevalence of testosterone deficiency in middle-aged to elderly men in the United States ranged from 24 to 39%, a prevalence much higher than that observed in other parts of the world. The prevalence of diagnosed hypogonadism in Europe was significantly lower than in the United States, ranging from 8 to 20%. Studies in Asia and South America demonstrate the similar trend, with the prevalence of biochemical hypogonadism ranging from 70 to 33%, but dropping to just half of that, 10 to 12%, when requiring the presence of relevant symptoms. Hypogonadism data is lacking in the Middle Eastern population, but studies from Jordan and Saudi Arabia show the prevalence of 8 to 24%. This is worldwide prevalence of testosterone deficiency, and this is a summary of key studies already mentioned previously. It is clear the major problem in estimating the prevalence of hypogonadism is the inconsistent data on what physicians emphasize most during diagnosis. While many similarities exist in testosterone prescribing patterns, there are also important geographic differences in the frequency of laboratory testing and use of clinical symptoms to diagnose and treat testosterone deficiency and hypogonadism. This is testosterone prescribing therapy in worldwide. Testosterone therapy can take several forms. It can be testosterone patches, testosterone gels, intramuscular testosterone supplementation, testosterone pellets, testosterone wafer, which dissolves between the lip and the gum. It is not commonly used because it must be taken twice each day and causes gum irritation in many patients. These are also some symptoms of testosterone deficiency, which acts on physical function as reduced muscle strength, impaired physical coordination, impaired balance, physical frailty, is sometimes cognitive function, impaired concentration, impaired verbal memory, also the sleep disturbances, fatigue, insomnia, falling asleep, staying asleep. It also affects reduced sense of general well-being, reduced energy and motivation, anxiety, depression, or irritability. Of course, and mainly sexual function, reduced sexual desire, infrequent or absent nocturnal erection, and erection on awakening, impaired erectile function, impaired ejaculatory function, or impaired orgasmic function. This is overview of available testosterone preparation, already spoke. Transdermal gels, oral buccal applications, injections, subcutaneous pellets, or topical patches. This will be flow charts for the process of care for the assessment and management of testosterone deficiency in adult men. Depends of borderline, different borderline. This is borderline European Urology Association, and also the required laboratory test for monitoring. These are also testosterone therapy. And this is also monitoring symptoms and monitoring laboratory tests after testosterone therapy. Depends also, does patient has desire to maintain fertility or no desire to maintain fertility. So we analyze here, analyze the guidelines for testosterone therapy produced by major international medical society, which includes American Urological Association, European Association of Urology, American Association of Clinical Endocrinologists, British Society for Sexual Medicine, Endocrine Society, International Society for Sexual Medicine, International Society for the Study of the Aging Male. So we use the term testosterone deficiency rather than hypogonadism, and testosterone therapy, not testosterone replacement or supplementation. So testosterone therapy in men with testosterone deficiency is a topic rife with controversy, including diagnostic criteria, which patients should be screened and treated, its link to adverse events, and how to monitor patients on therapy. So only AUA Endocrine Society guidelines were based on systematic review using meta-analysis of the literature, while the other guidelines were based on narrative literature review. So each of these guidelines define testosterone deficiency, we already spoken. So there's a total testosterone threshold, for example, for European Urology Association is below 340 nanograms per deciliters. For example, for the similar like International Sexual Society, and for the AUA is below 300 nanograms per deciliters, and for the British Sexual Society is below 345 nanograms per deciliters. This is populations for testosterone testing, which consider should be, or which guidelines consider which patients should be screened or not screened. Generally speaking, screening for testosterone deficiency in general population is not recommended. Screening for testosterone deficiency should be taken in men who report symptoms or signs associated with the testosterone deficiency, particularly sexual dysfunction, as well in men with obesity, type 2 diabetes, and metabolic syndrome, and these mentioned comorbidities here. This is pre-therapy adjuvant testing. So this is required or not required test. This is recommended for each society. Now we can see here, for example, difference between the AUA and the EUA guidelines, which says that in each LH should be recommended, FSH only if interested in fertility, for example, and the prolactin level should be requested if LH is low or low normal, and also if high prolactin with total testosterone below 140 nanograms per deciliters, then also should be recommended pituitary MRI screening. This is also key counseling points for the major adverse cardiovascular events, which are all risk on testosterone therapy, or there is a fertility concerns. Generally speaking, prostate cancer on testosterone therapy, each of these guidelines says that there is no risk for the prostate cancer for the patients who are on testosterone therapy. Similar is to monitor patients with testosterone therapy for polycythemia on testosterone therapy, to intervene if hematocrit is above 50%. These are treatment considerations for the Endocrine Society, European Urology Association, and Joint Society. So if there is a clinical symptom, therapy should be recommended. There's no need for clinical questionnaires, but there is a difference in serum total testosterone we've already spoken. So these are treatment considerations. These guidelines set different target testosterone range For example, your American Urology Association says that the high level of testosterone range should be at least 600 nanograms per deciliter, which differs from British Sexual Society, which is much higher. It is 865. But for the European Urology Association, the target testosterone range should be at least mid-normal range, and also the similar like endocrine society. But for International Sexual Society, it's a normal range. So on treatment patient monitoring, the timing of initial testing should be at least 3 to 4 weeks after starting topical cycles, or after injections for the American Urology Association. But for the British Sexual Society medicine, should be at least 3 months after starting. The similar is for the European Urology Association, 3 months after starting. So if we see all these differences of these guidelines, generally speaking, in summation, while there are some variation in certain topics not discussed with each individual set of guidelines, all organizations are in general agreement over most key areas. So all agree that testosterone deficiency is a clinical syndrome that requires a low testosterone level, as well as sign and or symptoms for diagnosis to be made. The exact threshold varies or is not provided, but the organization suggests a threshold level between 300 and 350 nanograms per deciliters. Only men meeting the criteria for testosterone deficiency should be treated. Consider screening asymptomatic men with certain conditions that increase the risk of testosterone deficiency. Exogenous testosterone therapy causes impairment of spermatogenesis. There is no evidence that testosterone therapy causes prostate cancer. Men on testosterone therapy require careful laboratory monitoring with the first year and annually after. The committees acknowledge limited data on cardiovascular disease and testosterone therapy. The consensus is to withhold testosterone therapy within 3 to 6 months of an myocardial infarct or stroke, or in patients with severe heart failure. Also, all guidelines recommend utilizing testosterone therapy for diagnosis. All of the committees agree that testosterone level evaluation should be performed in the morning with confirmatory repeat if the level is low. Thank you very much, and I hope to see you soon in person. All the best. Bye.